This is the endobronchial ultrasound station and how to use the needle and the scope to sample lymph nodes. First things first is know how to use the needle, because the needle is what will break your scope. Okay, and so we don't want to break our scopes. Why? Because it's incredibly expensive to repair, and it takes an amazingly long time to get them back. Okay, and it has to be sent out of the country. Now, the needle has several parts. It has an inner stylet, which will...
Am I okay?
We're working to our own time. There's a stylet to keep the channel clear. There is a lock so that you can keep the needle retracted. You can release this to extend the needle. So you extend the needle, you can see the needle coming out. You can vary the depth of the needle coming out by setting this at whatever you want, between 1 and 4 centimeters. It defaults to 2 centimeters, which works for most occasions, but occasionally you want to go deeper. If you go deeper, you can take this governor off and go up to 4 centimeters. It's better not to start with the 4 centimeter passes. Start with the 2, the way it's designed. It'll give him a heart attack if we break his scope, so we don't want that. And so we'll leave it locked. Now, there are 2 other parts to this. One is to lock it into place, and one is the outer sheath. The outer sheath I'll show you when it's in the scope. The other part of this will be when we apply suction. There's a syringe that locks, so you have suction in here for when you need suction. So that your assistant will be handing it for FNA. All right. Now I'm going to have my assistant hold that. I feel like I'm doing a magic trick. All right. And now the scope will give you an interesting view. You have, first of all, on the screen, you can have an image of the bronchoscopic image, you can have the ultrasound image, you can have them individually, or you can have them both, and you can have one larger, one smaller. And what I tend to do is leave the one larger bronchoscopic image for introducing the scope. Once I'm in there, I set it up like this. I have a small bronchoscopic image, and then the ultrasound image, so I can sample what I need to sample. Realize that you're looking at an angle anteriorly, 30-degree angle anteriorly, so that you don't want to be going straight, what looks like straight. You want to actually, you go in, if you're not intubating the patient, you have a bite block in, you go in along the posterior of the tongue, and you follow along, and everything should look like it's in front of you. And so the epiglottis should look like it's up there. The vocal cords should be right in the anterior part of the vocal cords, right at the anterior commissure. That's what you should be seeing, and that way you know you're going through. It's like if I'm walking looking like this and looking like that, if I then straighten so I'm looking straight, I've changed my whole orientation. Same thing with the scope. If you're looking straight, if it looks like you're looking straight on, it means you're facing posterior. Okay, and you'll catch on something. Once you're in the trachea, you have a little more room to move and center it because there's more room, but going through the cords. So if you like this, what it's going to look like is you'll be at the vocal cords, okay, and you're going to be looking right up anterior. So if you're at the vocal cords, you're going to be here, not here. So it's not like you're putting, a regular bronchoscope, you look to be right center. You don't want to be right center. If you're exactly center in the vocal cords, you're going to hit something posteriorly, catch on their retinoids or something like that. All right. Now there's a balloon that you can use. I use the balloon infrequently, although I always load it because I don't want to find myself in a position.
To avoid damage?
Not to avoid damage. It's you need approximation to the wall, and if it's difficult to make the approximation to the wall so that there's an air gap, you're not going to have a good image. You need a solid or liquid connection, not air. Now, I put it on because I view it as a negligible expense, and if I need it, it's there. If you find yourself not using it very often, you can always skip the balloon and, pull out and put it back and put one on at that point. You can't use the balloon if there's latex allergy. It's a latex balloon. That's the only thing to remember. Now, once you're in, you're going to be in the airway. And in this case, we're just seeing a wall, and I'm looking up at the anterior wall right now. So you're looking up at the wall. See, if I straightened it to look straight, I'm really, the tip of the scope's touching posteriorly. So I'm going to look for a lymph node. Here are a bunch of lymph nodes, a whole grouping of them. Now, you can get an idea of size based on the grid on the side. This is a 4-centimeter grid, but you can vary that. And if it's a large node, you can print
up and down.
So this is proximal, that's distal. And if you're not sure, watch what happens when I'm pulling it proximally. All right? So that distal is moving away. I'm pulling it proximally, so distal is moving away. And if I'm pushing it, I'm moving to proximal. That's moving to proximal, meaning I'm moving by it.
Is this dot supposed to show you something?
The dot is where...
I move it directly, and then
So the dot...
It's not for the same side. Picture.
Right.
I go.
So if you're advancing it,
yes.
yeah. If you're advancing it, if you're going that way, it means you're going that way, so the image is going that way, right? It's like you drive. You know, it's relativity, right? You know, he's standing right there. If I'm walking this way, he's going that way relative to me. All right. So we have Einstein right here. It's theory of relativity. And then this dot is the side the needle comes from. In this case, it's also proximal side. The side the needle comes from. It's not exactly where the needle comes from, and that's important because if you do it like that, you think it's going to come right here. What actually happens, it comes from about here and goes a little shallower, so that if you have a small lesion, a relatively small lesion, you're going to want to set it so it's a little bit to the left of the screen. So that's between in this scenario, the lymph nodes are dark like this. All right, and so let's say we wanted to, we probably need to lubricate this channel here, but let's find a different. Let's say we want to hit this one, okay? You could do, and we probably would hit it from here, but you notice I have it, no, this is a node.
Hypochondriac, it's filled with fluid or something?
Yeah, it's a gel of some sort. So this is what a lymph node should almost look like. They're not always this perfectly dark, but it offsets from the rest of the tissue by being darker. Now, it may be that it has fat in it or calcium or some vasculature, and so it may not look perfect, and it may be also eroded by tumors, so it may be irregular, and certainly not necessarily round, although sometimes it is, but usually it's here. Now, a vessel can look like that too, by the way, and if you're not sure if it's a vessel, you can either watch the pulsating, but breathing can make it look like it's pulsating, or you hit the color button here, and you have a Doppler, which you can move with this knob, okay? And if it was an artery, you'd see red, okay? And then you can turn that off. Now, if I want to stick that, I'm going to take the needle, and this is important. So the needle's going to come through. I look, even though I trust him completely that he's retracted it, I look, okay? Make sure it is. I advance it in, and we're going to advance it all the way in and lock it, okay? See, I've locked it into position, so it's not moving. Some people will retract this, some people not. I leave it like this. My colleagues leave it like this. Whatever you choose. Experiment. See what works better. Then, most important part of this procedure is I take this knob, I loosen it, okay? And I hold onto this knob to move the sheath. You see the outer sheath? You see it on the screen? Right there? And I want to move it so it's just barely visible. See, I see just the tip? That's still sticking out. You can put it a little further out if you're uncomfortable, but as proof, you can see it's sticking out of the scope. You want it sticking out of the scope so it doesn't damage the scope when the needle comes out. Then I'm going to drive to where I want to be. All right, I'm going to find a lymph node. Let's say I want that one. in this situation. I have it sitting a little bit to the left of the image. I'm going to release this. My thumb's down, so I'm up against the wall. I can always reposition if I'm not comfortable with it. And then I'm going to do a stab, okay? And if I go a little far, I can just pull back. And you see that I'm right in the lesion, right on the edge of the lesion in this case, but edges may have better yields than center, but it's better just to sample at various points in the lesion. Sometimes you don't have the perfect shot. There's a cartilage in the way and you have to take a different angle. You just play it by ear. And sometimes you have to have someone hold this while you're advancing it. As you get more and more experience, you don't really need all the extra assistance. You can get comfortable keeping things in place. Realize patients are often breathing, which is a good thing. You know, the first thing they teach you when you become a lung doctor, it's important to breathe. And so since they're breathing, things may be moving, and so you may be aiming for a moving target. So you try to time it. All right, once this is in, I'm pulling the wire out. I've cleaned the tip by moving it up and down. Yeah, I'm going to hand that to you. All right, and then I'm going to take the syringe, connect it, open the suction. So the suction, I'm going to go up and down a bunch of times, up and down in the lesion, up and down.
How many times?
People always ask that. Some people, yeah, there's one of my fellows always said she was taught 15 times in her training. I'd say a bunch. A bunch. Once you're done in and out here through the lesion, okay, and you try to stay in the lesion without coming out, you shut the suction off, then you relax your thumb and pull till it clicks, right? So I've retracted the needle. I've relaxed my thumb to not damage the scope. I've locked it. I then release it. I don't watch this. I don't do this and watch it coming out because it's going to only come out where I put it. And I'm watching the screen just in case there's something going on. This gets handed to the assistant. Often as it's pulling out, they're grabbing this and wiping it down with a gauze. And then I'm standing there still with the scope in the patient. Then I go to process this, and so it's either going on a slide or filter paper or a cytologic preservative. David does the filter paper thing. I don't. So I do a pass for a slide, and then I do 2 or 3 passes for a cytologic preservative. Although you could probably try to put a pass or 2 in formalin for a core. What I would do is experiment and work with your pathologist as to what works best. Now, first thing I'm going to do here is take this off, release the suction, so that when I push air through or reconnect this, I'm not sucking it back up into the channel. Now I'm also going to, I personally blow air through first and then put the wire through. I think it saves me a step. I blow the air, put the wire in, I'm ready to use it again. Some people push the wire first and then decide to pull out the wire and push air and then put the wire back. You experiment also. Some people swear you have to do just the wire. Some people swear you have to do just air. Whatever works. I don't flush it with a solution until the very end, and I'll use whatever cytologic preservative, not saline. Okay? Now, so I'm over where I want to be. I extend the needle. If you're at 4 centimeters, make sure whoever's on the receiving end knows that so they don't stick themselves. Put it over whatever you're squirting it onto. I will push air through. In this case, I didn't unlock it yet, but I'll push air through. And then I'll take this off and put the wire through. So, now be careful with the wire. Usually you don't have it bent this much, but also careful not to kink it here. Sometimes it comes out of the package kink there, and that you can't pass the wire. And then you yell at him. But if not, be careful not to bend it. If you're having trouble passing the wire, sometimes if you've done it so many times you just can't pass it anymore. But sometimes it's because you've got a kink there, and sometimes you could salvage it by just straightening that out. And put it in, get it all cleaned out. You then retract and lock it. Okay, you're ready to go again. When you go again, adjust the sheath each time. So do you need to try a pass? Somebody need to try a pass? Okay. You can come back by.